This is Brian Wormers recording a lecture for medical surgical nursing on the topic of intraoperative nursing. Here are your learning objectives. Members of the surgical team are going to be varied. You're going to have your surgeon, of course, and then surgical assistant, and that can be either a first assistant who is a scrub tech, a first assistant who is a nurse, or a first assistant that is a PA or an NP, or even possibly other surgeons. You're going to have anesthesia providers, often including anesthesiologists, CRNA, and then even some techs. You're going to have holding area nurses. There's going to be circulating nurses, so nurses that are in there and they document and they follow procedures and they go and get supplies. There's going to be scrub nurses who are right at the bedside handling equipment. There's surgical techs, which are very similar to the scrub nurse. There's specialty nurses, so if you're working with pain pumps or defibrillators or anything like that, you usually have a specialist on that in those settings. And then, of course, you can also be used for respiratory or ORTs or surgical techs, maybe used in addition to nursing staff as well. So an operating room tech. Minimally invasive and robotic surgery, so this is what we talked about a little bit before. So this is when you have ports that go into the body, into that abdominal cavity, generally speaking. And on some of those, they've got, like this one, this is your insufflator, so this is what puts the gas into this abdominal opening, as well as it's got the light and the camera. And then through this other port, you can take this in and out, meanwhile while this stays, and that way you can cut, you can cauterize, you can grab things, you can put things in little bags and pull them out. So you can do a variety of things through that port. But so this is your camera with an insufflator, and like I said, this is a multitude of tools. Generally speaking, we have probably 3 ports. Sometimes they are able to go all 3 ports through the umbilicus, through the belly button, and that creates less scarring, and that's a great thing to do. This is a common practice that we often use for choles, joint surgeries, cardiac surgeries, splenectomy, and even spinal surgery anymore. Potential injury, you can cause mechanical trauma by hitting things, nicking things, causing ruptures. You can cause thermal injuries from the heat from electrocautery, and on very rare occasions, you can actually cause a fire within that abdominal cavity. Environments of the operating room, so it's really made to be a safe environment. The layout, generally speaking, is all about the same. We want everybody in that room to be happy and healthy, because the patient's so exposed and vulnerable that if you've got a cold, then that can really put your patient at risk. Scrubbing, so you're going to get your scrubs on with your booties right here, including your hat, your eye protection, and your face mask. You'll wash, keeping your arms parallel to the ground. Generally speaking, we don't have to have our hands up like this anymore. The new recommendation is having a parallel. And then always use the foot pedals. You're not going to touch anything after this. You'll clean your hands in the operating room, put the gown on, the glove on, and somebody will help you, assist you to Velcro and tie. Anesthesia, so this is partial or total loss of sensation with or without a loss of consciousness. We're trying to do this in surgery so that our patient is comfortable and also so they don't move during surgery. General anesthesia is a deep sedation. They lose consciousness, and it affects central nervous system. So it can be one or multiple agents, and it depresses the CNS. And so they do lose loss of muscle tone, and they lose their reflexes. So it can be a gas, can be an injection, can be both. And then adjuncts to general anesthetics, so you can give hypnotics, you can give opioid analgesics for pain, and you can give neuromuscular blocking agents. Different stages of general anesthesia. Generally speaking, we can have analgesia and sedation, which relaxes them. They can get a little excitement, and then they go back into stage 3, where it's a deep anesthesia. Stage 4 is a little bit too deep, and then hopefully we are recovering from anesthesia at this phase. Complications from general anesthesia can be malignant hyperthermia, and we'll cover that in a little bit. Overdose of the drugs. We can talk about If we're not ventilating correctly, we can talk about if they have a reaction to any of those drugs that we give, or if there's problems when intubating. So malignant hyperthermia, this is an acute life-threatening complication. It can be genetic and it tends to have familial traits. What happens is that muscle exposure gets exposed to a specific agent and they tense up, they fire up. This leads to an acidotic situation, causes high temperatures within that body, leads to dysrhythmias, and ultimately can lead to death. So by high temps, I mean like 110 degrees, but that is a late sign of that. So treatment is dantrolene. So we do use that. If you have any questions, this is Malignant Hyperthermia website that you can feel free to go to. Manifestations of malignant hyperthermia can include tachycardia, skin mottling, cyanosis, myoglobinuria from the breakdown of muscle cells, a rise in carbon dioxide, and then, of course, the fever that we talked about. Local, this is kind of nice because it's in one particular spot, and you're trying to deaden in those and disrupt sensory nerve impulses in a particular region. So by doing this, the patient remains conscious, they're able to follow commands, and it's often supplemented with sedatives, opioids, or hypnotics. So you can think of this as field blocks, nerve blocks, spinals, epidurals. Those are all regional anesthetics. So with a spinal or an epidural, you're going into this space right here and then injecting it into that space. Some complications can include anaphylaxis if they have a reaction to the medication, incorrect delivery technique if it's not delivered where it's supposed to go. You can get some systemic absorption, and I've seen this. The biggest time I've seen this was in numbing a right femoral area for hernia repair, and it kind of went down his leg and actually affected his DTRs, and he couldn't walk. It did wear off in a couple of hours, but it was a little concerning of the patient at the time. Overdose of those medications and any local complications such as bleeding. Treatment of those complications, so just protect the airway. So ABCs, once again, notify the surgeon. And if they're bradycardic, of course, give epi. Moderate or conscious sedation is kind of a mix between the two. So they're at a decreased level of consciousness, however, they can still respond and follow commands. This does cause an amnesia, and common medications that we'll use to do a moderate sedation would be etomidate, propofol, diazepam, lorazepam, midazolam, meperidine, fentanyl, and this one, which I haven't actually seen. Can use morphine, and those are probably the more common ones. Collaborative management, so we got to do a timeout just like with any surgery. We're in sterile attire. We got to identify the patient, do a medical review prior to any of these surgeries. Surgical positions, we can place them in a variety of different positions in the operating room depending on what area we need to operate on. Potential for injury related positioning is that we're always concerned about ulcerations, and then we can actually cause obstruction of circulation, complications with respiration, and then nerve damage from laying in that position for too long. Of course, with any surgery, there's risk for infection, so we really try to minimize that with skin closure devices such as sutures and staples, as well as gluing and non-absorbable sutures. We might insert drains to drain out any permanent drainage or discharge. We're also going to apply some dressings over the top of that to keep that sterile. And then, they often have drapes over the top of them while we're doing the procedure. Some of the common skin closures, so sutures here and here. The difference between interrupted and continuous, of course, is that you're doing one, tying it off, and then moving on to your next one, which is preferred but takes longer. This is continuous, so you're going in, going out, going in, going out, going in, going out. And the thing that is bad about this is if you cut it right here, then the whole thing can kind of pull apart and unwind. Whereas if you break one suture here, the rest of them should remain intact. You can also use staples, which aren't commonly used. for most surgeries anymore because it causes bigger scarring. You can use retention bridges and stay sutures, which are bigger. And then I'm seeing more and more tape and adhesives, so gluing it. With this potential for hypoventilation during surgery, we always want to monitor the ABCs, make sure that they're breathing, they've got good circulation, the cardiac rhythm is one that's perfusing, and that their blood pressure and heart rate are adequate. This concludes this slide presentation. If you have any questions, please talk to your professor.